Hello, good morning all. This is Dr. Nagaraj from IAP Digital Media Team. Today the webinar with Dr. Pradeepa ma'am. So over to you, ma'am. Thank you.
Good morning all. I would like to welcome our mentors, our IAP President, Dr. Sanjeev Jha sir, and our IAP head, National Head. Our IAP WC National Head, Ruchivashni ma'am, and Dr. Mercy Jaya Prabha ma'am, our South Zone Head, and Dr. V. Janani, Tamil Nadu State Coordinator, and Dr. Radha Balachandra ma'am, Joint Coordinator. Thank you for making this event happen. Today, our topic is going to be on advanced physiotherapy in cervical cancer. So we have our respective resource persons, Dr. Anbupriya ma'am and Dr. Chandralekha Swaminathan ma'am. Our first session will be on the overview of cervical cancer, which is going to be conducted by Dr. Anbupriya ma'am. Welcome, ma'am. First, I'll give a short intro about Anbupriya ma'am. Ma'am has around 20 years of experience in this field of physiotherapy. And ma'am is pursuing her part-time internal PhD on urogynecology and has done a master's in physiotherapy in obstetrics and gynecology and did her bachelor's of physiotherapy in the year 2003. Ma'am is as an assistant professor at SRM College of Physiotherapy, practicing and also practicing as a consultant women's health physiotherapist in Move and Life Physiotherapy Center at Guduvanjiri. Ma'am has completed many courses as basic concepts in manipulative therapy and has completed a course on LAMA's antenatal training, and she's a certified life skills facilitator. Ma'am, shall we start your session?
Yes, ma'am. Yes, ma'am. Yes. Thank you for the a good introduction.
I have a long list of ma'am's professional experience and her involvement into the profession, where most of the female physiotherapists are missing.
Yes, ma'am. Yes.
Thank you for your time, ma'am.
Yes, sure, ma'am. Thanks for the opportunity. Especially when it comes at women's health, I would like to give a session anytime, any minute, even though I don't have a time also, I find time because it's my, I think it's my role. I'll take always OG as my part. So thanks for the opportunity, ma'am, again. And for the best introduction. Yeah, ma'am. Shall I start the session, ma'am?
Yes, ma'am. Sure, ma'am.
Okay, with your permission, I'll share my screen. Is my screen is visible, ma'am?
Yes, ma'am. We can see you.
Okay.
Yes, ma'am.
Yeah. Hope my voice is also clear. I shall start my session. Okay.
Yes,
so today's topic is about the overview of cervical cancer. The first part, which has been handled by me, and it will be followed by the other resource person regarding. It will be a continuation of what is our role in handling the cervical cancer patients. Let me give an introduction about what will be the learning objective at the end of my session is I will be confident in saying that my participants will gain a knowledge on what about the just and through an pictorial representation, what will be the parts of reproductive organs and why it is called as a cervical cancer, and why that site specific name has come, and what about the incident rates? Is it really mandatory to talk about this? And what are the causative factors and risk factors relating to cervical cancer, and the maximum symptoms and signs that we could address at different stages of cervical cancer, and how the pathogenesis is going on, and a short note about the managements, and detailed about the prevention strategies. So this will be our learning objectives of today's session. Before going into both this cervical cancer, especially on the clinical part, as a physiotherapist, I would like to stress that why there is an importance for a physiotherapist to know about cervical cancers. As of course, as a multimodal therapy, we will be in the team to handle these patients both preoperatively, postoperatively. So that is a known part for everybody. But apart from that, as a healthcare provider, we have a very major role in prevention strategies. So creating an awareness that can start from my home, from our home, and we can spread amount to our community, because middle income country like India needs the healthcare provider to take the first step in creating the awareness, preventing the occurrence of this preventable cervical cancer. So I think that, so this is this overview of the cervical cancer of my part is going to be an awareness, more of clinical part. It also include more of awareness things. So I think that's the key point, that every physiotherapist has to be very keen in learning about the clinical part of this cervical cancer. So starting with my session. So what is cervix? Yes, of course, women, even schoolgirls, even an adult with other elective persons, non-medical persons, doesn't know what is cervix. So they have to be aware about the parts of their reproductive organ. So as you could see in the picture, to keep it simple, yes, we all know that we have a uterus. Yes, woman has a uterus. So the uterus, the one end is connected with the ovary, which is going to give the ovum, that is the egg, and the other part that you could see, the mouth of the uterus. I'm going to move my cursor here. So this is the mouth of the uterus. This part is called as a cervix, and you could see a small indentation at the mouth of the uterus, and that will be followed by the vagina. So, and the ovary and the uterus is connected by a tube-like structure on both the sides, and that is called fallopian tube. So this is the reproductive organ, the parts that has to be known not only by a medical person, and non-medical person also should know about their parts. Okay, so now we know about the cervix. Why we have to learn about cervix? What is the important about the cervix is, as our topic says, it's about cervical cancer. Why we are not caring about some other cancers in the reproductive organ is, yes, we have a reason for it. So before going into the reason, first we look about what is special and what is the speciality about the cervix. Okay, so the cervix is the one part. You could see I'm going to scroll in another picture. The cervix is the one part that is during the developmental stage, the embryonic stage. It shares two sides of epithelial tissues. One is the columnar epithelium and the squamous epithelium. So I don't think that you need a better it's not like we have to go about how the cells will be looking at. Okay, then how it is going to connect. I'm not going to talk about more of embryonic stage, but the importance is the two cells will join together at this cervix part and the mouth of the uterus, and that is a specialty of the cervix, that that it needs to give expansion at the time of pregnancy and the delivery. Okay, so apart from that, since those cells will respond more to the hormones, the other part is, yes, of course, we also have that. Apart from other time of pregnancy, it also responds to the hormones, the deviations in the hormones, ups and downs in the hormones. So it is more vulnerable to the changes, the impact or influenced by the hormonal changes. But at times, what happens is This cells, like we could see, the cervix has been followed by vagina. Okay, so the cervix, as an ongoing process, a developmental stage occurs, the cervix, the layers of cervix might come, and there will be a change in the layers, so it will be more exposed to the vaginal environment. So that is one nature, that it puts always cervix at risk to get exposed to some sort of infections. So this is the reason why we have to know about the cervix and how to care about the cervix, and what are the prevention strategies that we have to take from our side. So going into the next slide, yes, now we have to address, okay, now we know what is cervix. Okay, now what about why cancer is going to happen? That I have given a small link about the cells underlying the inner lining cells, that has been how it responds to the environment as well as the change in the hormones. Okay, so as we know, cancer is nothing but, yes, of course, an abnormal and controlled growth of an abnormal cell is cancer. So when the cervical lining cells, the interepithelial cells is going to show the same changes, of course cancer can come in cervix. So cancer always named after the parts where it's been developed, even though it spreads along. Also, the first part which develops the cancer will be named from the first part only. So as the same, like lung cancer, oral cancer, when a cancer is the cancer cell growth can be seen in cervix, and it's called cervical cancer. Okay, next is, of course, we have to see about the disease burden, how prevalent it is. So according to the CDC, Center of Disease Control, have given a report that, of course, it is mandatory for every human being with both gender to know about the incident rate of this disease. So though Indian population all over the world, it happens to share like 1/7 of the world. India shares about 1/7 of the population. But in that, you could see the incidence rate that India represents 27% of the incident cases for cervical cancers. But at the same time, I think it's poor to think and to we can't even imagine that apart from the incident rate, there is morbidity rate also. You can see the death rate due to this cervical cancer, which is easily preventable, treatable in our country because of our low resource setting. You could see that the death rate is nearly equal to that. See, 27, that is 1/3 of the cervical cancer patients reported. Then 1/3 of that is reported from our country. So this is the poorest thing that we need to know, that we have to be very knowledgeable about when it has to be intervened. This disease has to be intervened. We have to know, and we have to spread our knowledge to the other community people. Okay, so here also you can see that this statistical report gives an comparison between the other cancers prevailing in the female population at all ages. You could see again, cervix cancer stands first. It is the most highest reported cancer when compared to the cancers among the females at all ages. Okay, what causes the cervical cancers? As I said about the place and the vulnerability. Okay, among most of the incidents reported, most of the positive cases, like 99% of the cases have found to have a positive test for this HPV, human papilloma virus. So it doesn't mean human papilloma virus only creates cervical cancer. It is responsible for other cancers also. But in case of cervical cancers, 99% it goes with this HPV positiveness. And in that, there are different types, like cancerous types is there, non-cancerous types is there. Cancerous type is the HPV 16 and 18, and this is responsible for more than 70 to 50% of especially site-specific reproductive organ cancer, cervical cancer, vaginal cancer, vulvar cancers. The non-cancerous type, that is 6 and 11, that accounts for the since the name itself indicates the non-cancerous cancer. So again, in and around the reproductive area, it will form like in warts. Both all the genital areas, it is represented as warts. So it's non-cancerous. But what causes, like we've seen this HPV, but is this HPV alone is responsible? No. In the presence of HPV, if there are some certain risk factors that will complement the this virus growth, and the infection rates will be more, and the progression will be more, I mean the growth of that virus will be high among those candidates who have these risk factors. Like if they are a perfect candidate of long-term user of hormonal, like they're going to take the contraceptives, or there is a history of early initiation of sexual activity like child marriages, then multiple sex partners, and sexually transmitted diseases, HIV, or there is a history of high parity, multi-parity women, more than 4 births, 3, 4 births. And if there is an already immune has been supposed, like any autoimmune diseases there, or they are taking any other medicine which is going to suppress their immune system, and they are in frequent tobacco users, especially smoking, both active and passive smokers. So these are the factors which will go along with the HPV, which will induces HPV to act more, especially on the cervical area, and it can start developing into a cancerous, carcinogenic effects can be produced. And what are the symptoms? Of course, earlier we have screening sessions, but once if the client or the population is having this cancer, earlier stages, there is no signs and symptoms to be seen. Because once they're going to exhibit the signs and symptoms, by the time it is in the advanced stage, mostly vaginal bleeding. The vaginal bleeding can be between the periods, or after intercourse, or if the woman has attained menopause and after menopause she could bleed. And when compared to the amount of bleeding, either between the periods it might be long, or even after menopause also, the longer duration of menstrual bleeding and the heavier of menstrual bleeding is, I'm telling about the quantity of menstrual bleeding will be more when compared to the usual stages. And regarding this vaginal discharge, it will be more watery, bloody, as well as foul smelling. So then, along with that, pelvic pain. Pelvic pain is the worst pain that keeps on changing in and around the pelvis. So we can't keep a track unless until it goes to a chronic stage. Then we call it as a chronic pelvic pain. Then, of course, dyspareunia, that is pain during intercourse. So along with that, the patient will also exhibit some sort of cervical erosions, which is non-healing, and it has been with a high recurrency. So with these symptoms, I would like to share some of the stages of the FIGO classification. It is nothing but like FIGO is the International Federation of Obstetric and Gynecological Association, which has classified the cervical cancers on the basis of the area where to which extent the cancer's growth has gone, and how many lymph nodes it has included, and which part of the area it also has included. Based on that, the classification has been made. So as a visual representation, I think you can just take it like stage 1, stage 2, and stage 3. We have some categorization. As I said already, the categorized is depend upon what are the characters they have chosen, but that is fine. We'll go with the next slides. So coming to this with the stages, what we have to think is how we can correlate these stages and the symptoms is, earlier stages, I said there will be no symptoms will be exhibited. Only at the advanced stages, the symptoms will be exhibited. Okay, but one thing we have already conveyed, that how cervix is most affiliated towards this HPV, and why the cervix cells is more reactant to the hormones. Okay, so in the presence of infections, and again there is in the presence of all those risk factors which we have discussed, what will happen in every woman, doesn't it? It's going to happen in every woman. So every woman they'll go for some sort of cycle. They enter into some sort of cycle, like they go for some infections, but it will get healed, it will get healed. And again, if it is not treated properly, if again the risk factor is going to be high, there will be being again the infection is going to persist long. So the cycle is going to be on in active mode. So what's the data evidence says that before she's going to tag us and she's having cervical cancer, it's going to happen. It literally takes 15 to 20 years of the lifetime for the cervix, the normal cervix, to get transformed into a cancerous growth cervix. So we have 10 to 15 years, good valid years, where we can intervene, where we can increase the awareness, and we can take them to some screening measures, and we can put some prophylactic measures, which we are going to tell now. So this is the importance of this slide. So the infections and the risk factors that doesn't on one night or one day, it's not going to change the normal cell into a cancer cell. It takes 15 to 20 years. So that is a good thing in this, that we could handle it. And one thing you need to know is CIN. CIN is nothing but cervix intraepithelial neoplasia. These are the 3 stages which tells about the precancerous stage, where the cells goes for changes. So the cells means the underlying layers of the innerlying layer of the cervix. These goes for changes. And I said why these cells are affiliated, because I've already quoted that because at the embryonic stage, how it shares the 2 sides of embryonic side. So that is why it is more affiliated. Okay. So it's more prone to have such changes, and it also gets healed. So it means that it responds to a treatment, it responds to the care if we given at the right time. And how to diagnose? Yes, the initial screening measure is pap smear test. So in our India, like low resource setting, the pap smear test is like, it is for the physicians, it is like a gift, as well as for the patient is also a gift, because they can do it rapidly, and they could take the measures, and they could just then use it as a screening measure, and it's also easily available. So so that's the first diagnosis. If it is positive, then we'd go for a colposcopy. Colposcopy is nothing but it is it's a visual observation technique. They're going to put a scope inside through the cervix, and they're going to visualize how the layers is or how the erosion is. And if needed, they could take a biopsy. And the other one is cone biopsy. So cone biopsy is nothing but a large loop excision of transformation. Its own is nothing but I said about the cervix, the junction where the 2 layers changes. So it is more prone to get the precancerous growth. So that area, they're going to take a cone biopsy. Just like cone, they're going to take the tissues out in a form of cone. So as an interest, I want to show you how this epithelials erode, how it will be looking like in a colposcopy. We could see the different stages, C1, SIN 1, SIN 2, SIN 3. This is how it initially starts, and later, if treated, it can come to like CN 3 can come to CN 1. Otherwise, it goes for the FIGO stages. Okay, the managing them, of course, as I said, any cancer has not been managed by a single person. As cervical cancer also, it has a team. A general physician will be there, who's the first person who will be giving a proper referral. Then a gynecological oncologist who's going to diagnose properly and do the confirmatory test, and will advise for the treatments. And the radio oncologist comes, and they play the role through radiation therapy. Then the chemotherapy will be given by a medical oncologist. Then cancer care coordinators, of course, it also involves us and the family members, the dietitians, and all other allied health professionals who are part of this team, like pharmacists, counselors. So everybody have a role to play in managing or treating or supporting the cancer patients. So apart from the medical management, surgical management, yes, of course, when the patient is in the pre-invasive cervical cancer, yes, laser therapy, like I said, when they're going to take the biopsy the same way. They might do the cryosurgery in case of an SIN 1, SIN 2. Okay. But if it is an invasive cervical cancer with like FIGO stages have gone, then they go for the surgical removal of the part, like a hysterectomy will be done. Either it is a simple hysterectomy or radical hysterectomy where the lymph nodes also will be removed. Then again, it will be followed by a perfect chemotherapy and radiation therapy. Then this patient is enter into a rehabilitation program where will be managed fully by a physiotherapist and the other healthcare workers. Okay, then the primary prevention. What is the primary prevention that has been suggested by WHO and it's accepted by universally is yes, HPV vaccine. HPV vaccine is mandatory for girls before 15 years. So the time period is within 9 to 14 years. The girls can be vaccinated through this. Then of course it is chargeable, and these are two varieties that is prevailing in the markets. And yes, always ask a question that is it possible to get protection against cervical cancer? Yes, it is protectable, it is preventable. It is very easy to prevent rather than managing. So it is not a myth, it is a fact that has to be addressed by healthcare professional. So the prevention strategies is very simple. Have the HPV vaccine and followed by a routine pap smear test. And as we saw the risk factors, we could address those risk factors, practice safe sex, counsel regarding that to the people who's having multiple sexual partners, and quit smoking and do some lifestyle modifications where we play a major role in prescribing exercises, making them fit and leading their life healthy and improving their quality of life. Okay, apart from this prevention strategies, I would be like to tell that WHO has initiated a cervical cancer elimination initiative. So what is that initiative is? It tells about three major domains: vaccination, screening, and the treatment. So 90, 70, 90. So that's a target telling that every girl before the age of 15, when they reach their 15 years of age, 90% of the girls should be fully vaccinated. And these strategies is for the worldwide. Every country has to follow this. Then they are working towards that. And regarding the screening strategies, yes, before the age of, like at the age of at least 35, 75% of women has to be screened with pap smear test for this presence of HPV. And again, one more screening has to be done at the age of their 45th age. Then the treatment, yes, 90% of the women who is in the precancerous with pre-cancer treated, and 90% of women who are in the invasive cancer has to be managed. So this is the target. So what the WHO tells is by the end of 2030, so the targets has to be met. So meaning every country has to give an incident report, like the prevalence should be for 1 lakh women, 4 women has to be positive for the cervical cancer. So that is the with this initiative they could achieve that. So that is what the WHO is insisting us to do. And I would like to summarize my points. Yes, cervical cancer is the 4th most common cancer among women globally, and HPV is the main culprit because it has been addressed in 99% of positive cases. Yes, of course, this HPV is transmitted through sexual contact. It has to be a direct contact, even from mother to at the time of birth to the child also it's possible. So then also the women who living with HIV are 6 times more likely to develop the cervical cancer. Like multiparative women, 4 times she's in risk to get this HPV. Then again, the screening, treatment, and vaccination is very effective, and it has been proved in preventing, especially in pre-cancer stage. they find out that we have discussed about sin 1, sin 2, if we are going to find out that if the population has been addressed at that stage, it is preventive and it is effective and it's cost effective also. Because when the question arises about the HPV vaccines, the money used or money to buy it, I think at the life-saving point, it is cost effective. And of course, cervical cancers can be cured at the earliest stage and treated promptly when it has been addressed then and there. Of course, as we said, it's a multimodal treatment, as well as we have in primary, secondary, and tertiary level. Yes, tertiary level is always a treatment. Of course, primary is more effective because vaccination is very easiest thing that we could give and suggest. And secondary prevention, of course, screening and then the treatment followed for this pre-cancerous patients. So I think I have delivered my session and justified my session. If you have any queries, you can please ask. I'll try to answer with the proper evidence support.
Thank you, ma'am. Thanks a lot.
Thank you, ma'am.
That was a wonderful and knowledge receiving session. Thanks a lot, ma'am.
Thank you, ma'am.
Let's welcome our second session resource person, Dr. Chandralekha Swaminathan, ma'am.
Shall I stop sharing my screen, ma'am?
Yes, ma'am. A short intro about Dr. Chandralekha Swaminathan, ma'am. Ma'am, ma'am, can you, Anbupriya, ma'am?
Yes, ma'am. Yeah, ma'am. Can you hear me?
Yes, ma'am.
I have stopped sharing
your video.
You can start sharing, ma'am.
Yes. Yes. I'll give a short intro about Chandralekha Swaminathan, ma'am. Ma'am joined as a trainee in clinicals at Sri Ramachandra Medical College and Research Center 15 years before. And now she is specialized in oncology specialty. And she has done 2 publications on return. And she's interested much in women's health and oncology and is one of the sub-coordinator of IAPWC Kanchipuram district. Welcome, ma'am.
Thank you, ma'am. Thank you for your wonderful intro, ma'am.
Shall we start the session, ma'am?
Yes, ma'am. Yes, ma'am.
I'll be sharing the screen for you.
Yes, ma'am. Can I start, ma'am?
Yes, ma'am. Yes, ma'am.
Yes, ma'am. Good morning, all. It is an immense pleasure to be a part of this webinar. I'm here to share my knowledge on the physiotherapy management of cervical cancer. Treatment for cervical cancer might be a surgery, radiation therapy, chemotherapy, targeted therapy, and hormonal therapy. Once the patient is diagnosed as a cervical cancer, the treatment will be decided by a tumor board. Every specialty hospital, they're having the tumor board. The tumor board, including the surgical oncologist, medical oncologist, radiation oncologist, and micropathologist, gynecologist, and general surgeon, multiple persons. They will decide when the patient will go for the surgery, will go for the chemotherapy, or will go for the radiation therapy and extra. Next. Post-operative management, the healing process, it takes a time and incision to heal. After 2 weeks, the wound only has to be a 10% of its original strength. By 6 weeks, most internal healing will be occurred. The tissues have regained 75% of its original strength. Approximately 4 months, full potential strength has occurred. This only every 80% of the original tissue strength. Even when the external scar tissue has formed, the internal healing will be there. It is an essential that you do not strain the operated area while this process occurring in order to minimize the benefits of a surgery. We have to give the detailed education to the patient. Next. Post-operative day 1. We can start with the respiratory care and circulatory care, ankle pump exercise, active and assisted mobility exercise, and deep breathing exercise, air clearance techniques, splinting, incision, puffs and coughs, incentive spirometer. Next one. Breathing exercise, you can know about detail in all breathing exercise. You have to take a deep breath through your nose and slowly you have to do breathe out through your mouth, 1:2 ratios. Next one. Coughing and coughing technique, you can support your suicide side. You have to cough through your bottom of abdomen, how to do and bring it up your secretions. It will the helpful techniques to who are the patient in day 1 to bring out the secretions. Next one. Day 2, we get continue with the ankle pump exercise to prevent the deep vein thrombosis, active mobility exercise, sitting on the edge of the bed, breathing exercise to clear the respiratory tract, and splinting the incision for cough and cough, supporting the ablation in the in-bed long sitting. Next. Also, we can start with the quadriceps contraction, the in-bed mobility exercise, knee rolling, pelvic bridging, SLR, and initial stages of Gegel's exercise. Next. We have to teach the patient detailing how to get up from the bed and how to back to the position. The way they have to be in supine lying to log roll position to the side lying, either right or left, then go to the push-up with the help of elbow and hand support to get to the sitting posture, and they have to sit on the with some physiotherapy support in the edge of the couch, along with the feet touched in the floor or in the footstools. Should not hang over the heels to give the full support of the sitting. Next one. Day 3, we can go with again to prevent the deep vein thrombosis, ankle toe pumps exercise, active mobility exercise in sitting, breathing exercise, airway clearance techniques, splintings, ablation up to the 30 meters. It may be around the car, around the bed, inside the room, 3 to 4 times in a day, along with the incentive spirometry. Day 4 to 7 might be patient in the independent bed mobility with the supervision of physiotherapist or attenders. My active mobility exercise in sitting and breathing exercise, airway clearance. Again, all the exercise 3 times or 4 times in a day, increase the distance gradually, and incentive spirometer. In this period, we have to educate the patient to sit in more times and be in active in the daytime. Do not go bedtime in the morning times to avoid a morning sleep. Extra education we have to give the patient, and the same time we have to educate the attenders also to do the exercise regularly in part of gap. What are the importance of the exercise in the cancer patient? The physiotherapist role in more than the patient is the caregivers. When we are explaining to the caregivers the importance of exercise only, the caregivers will encourage the patient to do the more intensity of exercise and the mobility to avoid the deconditioning of the patient. Next, ma'am. Posture and back are always important to the patient on all the diagnosis. It is very important to be aware of your posture, to take a special care to about the 6 weeks after your surgery. A good posture will help prevent the back. Sitting also, sitting with upright support chair with arm rest and the 4th feet on the floor should be a good thing. Do not slouch and should not hang over the foot. Standing and walking, avoid holding your tummy, your hands. 1 second, ma'am. Avoid holding your tummies and in the slouch position. For that, we can give with the patient for the abdominal binder while mobilizing the patient. The binder, we need at least 3 months in the healing process to get over. Okay, next we'll go with the radiation therapy. If the radiation therapy pelvic floor complications are fibrosis. Fibrosis means narrowing, the shortening of the vaginal canal. The shortening of the vaginal canal will lead the pelvic pain, pain with the sexual intercourses, urinary and bladder incontinence. This is the main major complications after chemo or radio or surgery in part of cervical cancer. Next, ma'am. Ma'am, can you go to next?
1 second, ma'am.
Okay, then the pelvic pain, we can go for muscle trigger and vaginal dilator. Yes, ma'am, next. Chronic pelvic pain following the cervical cancer treatment, the more sexual dysfunction related the considerable distress. Pubic bone symptoms increase the frequency of the pubic bone pain with the means observed and existing pubic bone. Cancers, however, treated with the radiation therapy alone reported the higher prevalence of the hip pain. The vaginal dilators prevent development of vaginal stenosis following the radiation therapy as reviewed by the Cochrane collaborations. Next, ma'am. Using vaginal dilator, crook lying with the legs abducted, stand with the one leg bent with the kept in a stool. Using a vaginal dilator is a simple. It should not cause any pain if you do it slowly and gently. It should take about 10 to 15 minutes. Start with a smallest size dilator in the kit because of narrowing of the vaginal canal. So we can start with smallest one. Dilator should feel snug but not painful. If you don't feel any pressure when the inserting this dilator, you might need to use a larger size because it's already the needed opening is there. Apply a water-based lubricant to the dilator and opening of your vagina. Using a gentle pressure, slowly insert the round ended of the dilator into your vagina. Always insert a straight toward your spine back at a slightly downward angle. Keep inserting the dilator slowly until feel slight discomfort or muscle tension. Then stop. Never use forcefully. Stop if feel pain also. And also, I'm little bit down. Yes. You have a gentle move with the dilator inside your vagina for 5 to 10 minutes. Gently push the dilator in and out. This helps stretch the length of the vagina. Gently rotate the dilator in wide circles at the back, middle, opening of your vagina. This helps stretch wide of your vagina. It may helpful to work with more than one size dilator. For example, you can use a larger dilator at the opening of your vagina and a smaller dilator deeper inside over vagina until you are able to use the next size dilator fully. Take the dilator out of your vagina for using your vaginal dilator. Wash your dilator with the hot soap water. Dry it with a clean towel or paper towel. Store it as instructed in your kit. You may have a small amount of vaginal bleeding while using a dilator or after you are finished using it. This is normal one. If the bleeding continue for longer than 1 day, call your healthcare provider. The goal of the vaginal dilator therapy is Increase the size of your dilator slowly. When you can insert one side of the dilator complete into your vagina without your discomfort, you should start using the next size up. You should do dilator therapy 3 to 4 times per week. Next one. Bowel and bladder incontinence. Pelvic floor physiotherapy, patient position, sitting, standing, lying, or lying with the hips elevated according to the stop test scores. Instruction: stop urine, stop motion or gas, contract the vagina, contract all three together, lift out towards the umbilicus. You have to educate the patient clearly while teaching the giggles exercise. Should not try with whenever passing the motion, whenever passing the urine or else. It is the technique to educate to contract the muscles alone. Slow stretch repetitions, evaluation 3 seconds, holding, training holding period 3 seconds, rest period 6 seconds. Repetitions 4 to 5 times in a set. So per day they have to do sets of 5 to 6 times in a day. It's around 30 to 80 contractions. The time period of resting is must needed relaxation time. If incomplete relaxation time, the results will be the hypertonia of muscles or the no functional outcome. Fast stretch repetitions determine the number. Hold period less than 2 seconds. Accessory muscles, when we going for the accessory muscle contraction to train the pelvic floor muscles, when the pelvic floor muscles will be the less than 2 by 5. Abdominals, gluteus, adductors, we can use according to the accessory muscle to train the pelvic floor strengthening exercise. What to not be done, breath hold do not do, and relaxation period must be there. Next. The nut technique, we can educate the patient who are known case of already incontinence of fecals or urine. Whenever they're going to be a sneeze or cough, ask the patient to contract the muscles and they have to do the sneeze or cough to prevent the pills. It is the good technique to educate the patient. Next. Pelvic floor strengthening program is good to the patient. The muscle work in the co-coordination with the pelvic floor. Some enhance the contraction of the pelvic floor and they stabilize the pelvic and the lumbosacral spine. Who needed the strengthen deepest core stabilizer, then follow the optimal contraction of the pelvic floor. Next. What are the muscles we have to do? Then the pelvic floor transverse abdominis, multifidus. Next one. Next. Adductors and hip rotators. Next. Effective of pelvic floor exercises. According to the 1989 Johnson, pelvic floor coordination with the weight count showed greater strength gains than muscle coordinations alone. And 1994, Candy suggests the pelvic floor exercise promotion should be in the adolescence rather than the after event. And according to Hanela 1988, studies have found that improvements with the pelvic floor exercises. Next. Physical deconditioning. This is the main thing we have to educate the patient caretaker and the patient. When the patient is the cancer diagnosis, they may be in the malnourishment and less physical activities. So we have to educate them clearly. And also physiotherapist in team of rehabilitation, the dietitians will be a part of the member. But even though the dietitian will educate to the patient, when the physiotherapist also to enhance the patient to take the adequate nutrition of high-rich protein diet to do the physical activity needed manner. To avoid the deconditioning. Deconditioning is nothing but a complex process of physiological changes following a period of inactivity or bed rest or a sedentary life. This will lead the many patients to not to obtain the quality of life. So physiotherapists have a big role in that to avoiding the deconditioning. So pain relief, improve the strength, flexibility, and optimizing the functioning. Next. And physical activity to encourage the patients, the moderate in according to the WHO, the moderate intensity of physical activity per week is 150 minutes, and vigorous activity per week is 75 minutes according to the patient ability. Next. Next. How regular exercise may help you before, during, and after cancer treatment. Help your body and brain work better, reduce feeling tired, fatigue, help lessen depression and anxiety, might help you sleep better, keep or improve your physical ability to get things done, improve your muscle strength, bone health, range of motion, strengthen your immune system, increase your appetite, help you get to maintain a healthy weight, many help with related the cancer disease risk factor to reduce, decrease the chances that some types of cancer will come back, improve your quality of life, reduce the treatment of side effects. Next. Cancer-related fatigue. If cancer-related fatigue is greater than 10 times of normal fatigue, we have to explain the patient that symptom is, it will be like this. We have to overcome with the fatigue is only by a physical activity. Next. Mitchell method of physical relaxation, we can encourage the patient to do this. Pull your shoulders towards your feet, elbow out and open, fingers and thumb long to support it, push your body down, turn hips outwards, push feet away from face, push head back, open mouth, raise eyebrows. This is the muscle relaxation technique to educate the patient for to avoid the fatigue. Next. Some relaxations they can go for whatever they want to do, yoga, reading, talking, listening music, whatever they want to do, they can do. We can promote them to do that. The main the main complication of later complication of post procedure of cervical cancer is lymphedema. Lymphedema is the one of the most complications to reduce the patient's of quality life. We are the therapists having the biggest role in preventing the lymphedema. If also it's diagnosed the lymphedema, we are the playing the important role to reduce the lymphedema to help the patient to do a quality of life. Symptoms of lymphedema is a feeling of heaviness and tightness, swelling part of all of your leg, thighs, legs, foot, toes, difficulty in moving, aching or discomfort, skin hardness or tightness, folds developing on the skin. Next. Stemmer signs test. Stemmer sign is a thickened fold of skin at the base of the second toe or the finger that can be gently pinched or lifted. The presence of this sign is most often an early diagnostic indication of primary lymphedema. However, it can also develop the later in a secondary lymphedema. A positive test result is present when this skin cannot be lifted. This considered to be an indication of the presence of the lymphedema is the only test for the lymphedema in clinically diagnosis. Next. This is the picture for the Stemmer's test. Next. Lymphangiotography is sometimes used to diagnose primary lymphedema by identifying the location of the fluid built up. It helps the doctor to create a map of how a lymph flows and drains, where it is blocked, and the lymphatic system. Before the scan, a small amount of home cells radioactive dye is injected into the leg. A scanner detects the movement of the dye through the lymphatic system. The detector monitors and the computer screen. The scan reveals the location and degree of the blockage in the lymph vessels. The test generally takes 30 minutes to several hours to complete, depending on the patients. So you can see in the diagram where it was the fluid accumulation. Next. Complete decongestive therapy is the golden standard therapy for the lymphedema, even though if it is in post-operative breast cancer, the lymphedema in the upper limb, or any case, reproductive system cancer post-operative in the lower limb. Complete decongestive therapy is considered of the lymphatic drainage, massage, exercise, and this short stretch bandages. It has two types, initial period and the maintenance period. We have to assess the lymphedema as the segmental measurements, circumference segmental measurements, comparison with the normal legs. Once the patient is diagnosed with lymphedema, we would start the decongestive therapy. It has a separate kit for the decongestive therapy. It is a 24 hours application. We have to educate the patient in self application also. If they're not able, we have to ask the patient to come for our OPD. At least minimum 2 weeks of regular pattern to reduce the, once we have to reduce the swelling, then we have to go with the maintenance phase. Patient has to do the quite long period until get the normal. We have to compare with the patient's measurement with the same of other limb. If the patient having the right leg, means we have to compare with the same person the left leg, not to the other persons. Next. Elevation of lymph is must. Next. Compression hormones will give this compression hormones the once the patient is suture removed. It means the second week of surgery, the first review to the physiotherapy department, and after the discharge, we have to educate all the exercise against the gravity for the lower limbs and the limb elevation and the frequent exercise along with the compression hormones. The compression hormones we use for the patient is prevent the lymphedema, also the maintaining the lymphedema. Next. The exercise, we have to do all the lower limb exercise in the against gravity. Next. Outcome measures for all the complications, including the lymphedema, fecal, urinary incontinence, fecal incontinence, pain in the pelvic bones, everything we have the outcome measures that I have listed out. Quality of life, brief, we can go with this tool. Next. Urogenital distress inventory scales. Next. Next. Urogenital distress inventory scale of questionnaire method. Next. For the study evidence for the scales. Next. Incontinence impact questionnaire. Next. Next. Scores for the questionnaires. Yes, this is the studies for the supporting article. Female sexual functional index scale. The next, ma'am. For that scale studies. Next. Pelvic floor disability index scale. Next. Pelvic floor impact questionnaire scales. Next. For that references. This is a month we are celebrating the cervical cancer awareness the every January month. So thank you for Pradeepa madam who have taken this opportunity to talk in the month of cervical cancer month. Thank you, ma'am. Next. Thank you all. If you have any doubts, you can ask me.
Thank you, Chandralekha ma'am.
Yes, ma'am.
For this wonderful session.
Yes, ma'am. Ma'am, any doubts for anyone?
First, let's check the chat box.
I thank IAP Women's Cell and IAP President Sanju Jha sir, IAP President Dr. Rushi Varshini ma'am, IAP WBC National Head, Dr. MC Mercy Jaya Prabha ma'am, South Zone Head, Dr. V. Janani, Tamil Nadu State Coordinator, Dr. Radha Vengadachalam, Joint Coordinator, and my team member, Kanchipuram District WPC Coordinator Pradeepa ma'am and Sudha ma'am. And I would thank to Srihar, all of my faculty who supported me to take in this presentation and staff members encouraging me to participate here. Thank you all.
Thank you, ma'am. Thanks a lot, ma'am. Any doubts? Can share in the chat box.
Three participants has been raised their hand.
Okay.
I think if it's for the query, I guess. Kindly post your question in the chat box. Pradeepa ma'am, I'm just
Yes, sir.
allowing them to talk.
Yes, please, sir.
So they can ask the question there.
Sure, sir.
Dr. Rajitha Khandi, I'm just allowing you to talk. Please unmute your mic and ask your query. Dr. Rajitha Khandi, you have raised your
She can
hand.
unmute herself.
Yes, yes. Can you please unmute? No, okay, no problem. Mubina Nahimullah, I will just allow you to talk. Can you please unmute?
Good morning, sir. And my question is about HPV vaccine. Do we have any age limits for taking up the vaccine, or is it like any women under any age can take up?
Like it is before 15th, it is good to take. But after, they have to do a screening test, and with the guidance of the OGCN, as soon as possible, they will be giving the vaccine. It is after a screening test, they will be doing the HPV after 15 years. Like after 30 years, if they are going to have a doubt and they have to do, they will be doing a a pap smear test, and with that, the vaccination will be followed. Hope I have answered your question, madam.
Yes, ma'am. Thank you so much.
Yes.
Next is Ajita Kulkarni. Can you please unmute and talk if you have a query? I hope no. Pradeepa ma'am, please.
Yes, sir.
You can continue, ma'am. I think there is
Yes,
no
sir.
questions.
Okay. That was really a wonderful session. And that was a very good knowledge sharing from both of you, ma'am. Thanks a lot, ma'am. That too on a Sunday morning for making this to happen. I would like to thank you, Dr. Anbupriya, ma'am, and
Thank you,
Dr.
ma'am.
Chandralekha, ma'am, for making this to happen.
Thank you, ma'am. Thank you for every organizers who have taken this initiative. I think, and that too on Sunday. Like you should have a the preparatory work, just like us. You people also have done. You have also like availed your quality time to this session. So thank you, ma'am. It's to have is to mingle with your wonderful team. It was like, I think it's my first collaboration with you. It was very fine for me, and will be a rememberable session for me.
Thank you. Thanks a lot,
Yeah.
ma'am. Once again, I would like to thank our mentors, our IAP President, sir, Dr. Sanjeev Jha, sir, and IAPWC National Head, Ruchivashni, ma'am, and the great support of all the female physios in India. Ma'am is the Iron Lady, and she's the big pillar of us. And I would like to thank Mercy Jayaprabha, ma'am, our South Zone Head, and Dr. Janani, ma'am, our Tamil Nadu State Coordinator, and Dr. Balachandra, ma'am, who is our Joint Coordinator. And let's rock.
Thank you, ma'am. We'll do it.
Let this 2023 be, we'll share more health issues, and we'll help the physios and as well as the public, and we'll create awareness more and how physiotherapy is going to help them. Let's hold on to it.
Thank you, ma'am.
Yeah, thank you. Thanks a lot,
Yes.
ma'am. Thanks a lot. And once again, thanks a lot for the participants for staying patient and making this event beautiful. Thank you.
Okay, ma'am. We'll end the session.
Yes, sir.